So I guess one of the questions that we should ask ourselves is, why has there been so much kind of controversy or hesitation to use long-acting injectable medicines? I mean, we feel that the evidence is pretty clear, but I guess there are many clinicians who are hesitant, and I think part of it is there's a misperception of what it means to put someone or to recommend a long-acting injectable, that somehow it's viewed as coercive or we're taking away the patient's autonomy, and I think that's an unfortunate misperception. In my mind, we are actually trying to help the patient achieve more autonomy by giving him or her more control over the illness from which they're suffering. And that as I said earlier, we should not convey that injections are somehow punitive, but unfortunately, the way many clinicians present this to patients and families is in a kind of negative light. They talk more about the injection than they do about the benefits. And I think we have to do a better job of training ourselves and our colleagues as to how to have these conversations, and so that these formulations are not viewed in such a negative light. I think the other thing that sometimes enters into this conversation is there's a tremendous push from some quarters to identify patients who may not need medicine or who can use very, very low doses. And I think that also is confusing, because the long-acting injectable in no way implies, it's no different from a decision to use medication, whether it's oral or long-acting. The first judgment that needs to be made is medication indicated? And if it is indicated, then why not use a long-acting formulation? But I think people kind of confuse those issues sometimes.
But John, I have an answer to your question. Why are they not being used widely? I think the reason is ignorance, and it's very specific type of ignorance. People in the 70s, when Prolixin came to the market in the US as the first long-acting, nobody used it, okay? Because of attitudes of psychiatrists. I let my patient make their decision. I respect the patient's decision to make to decide what they want, without realizing that they have a severe brain disorder that impairs their ability to make decisions. And then it gets worse. But there was absolutely no knowledge until 20 years ago that psychotic relapses destroy the brain. They are neurodegenerative. They are damaging to the brain. Nobody knew that in the 60s, 70s, 80s, 90s. Nobody knew that. And so long-acting injectables were not taken seriously because they didn't know how serious and devastating psychotic relapses are to the biology of the brain of the patient. So because of that ignorance, they thought of it as an option. Let the patient decide. I don't want to force myself on the patient. I don't want to be paternalistic. Let the patient exercise their civil liberties. In other words, they destroy themselves by exercising the wrong decisions for themselves. But only in the last 20 years, we realized that, literally. When we started doing MRI scans repetitively and realized that the brain was undergoing atrophy with every episode, that's when we realized how urgent the matter is. Nobody took it urgently. And there's a whole generation of psychiatrists who were trained in the 60s, 70s, 80s, 90s, who are still practicing, and they still have the same old attitudes that this is an option, and they don't realize how urgent this is to save young people's lives.